Thank you. Hi, everyone, and welcome to the presentation. So thank you for the kind introduction. And just to restate that I am Professor Rhiannon Evans at Cardiff University, and today I'm going to talk about process evaluations. So I will try to keep the presentation till about 40 minutes to allow for questions afterwards. And also to note that there are some slides in the slide deck that I probably won't get to today, but they're more for information for you to look at in your own time. So just to quickly outline what we will cover in the session today. So I'll start by introducing the Medical Research Council guidance on intervention development and evaluation. I know many of you will be familiar with this, but for those of you perhaps more new to evaluation research, this is always a really good place to start and entering into evaluation work. Then I'm going to touch on program theory and its importance around process evaluations. And then I'm going to go through the different domains of process evaluation that we tend to look at. And within this, I'll look at that idea of how does it work and potential harms. So just to flag who I am, following the introductions, so my name is Rhiannon Evans. I am a Deputy Director at the DECIPHer Research Centre. So this is the Public Health Research Centre in Wales. And then I also work around a range of other infrastructures, including the NIHR reviews team. I'm also co-investigator on the recently established National Welsh Centre for Suicide Prevention and Self-Harm Research. So the starting point in the story really that I wanted to come to you with today is around the MRC guidance for the development and evaluation of complex interventions. So looking back nearly 30 years now, there was a sense amongst funders, governments, various organisations that the quality of public health research in the UK was not at the standard we might expect and didn't meet international standards of what other countries were doing. So a number of the key funders, including the Medical Research Council, invested in research centres, including ours, and also establishing methodological best practice of how do we do good science, and in this case, how do we do good evaluation science. So they initially commissioned guidance in 2000, and then they've periodically updated this guidance every 10 years or so to reflect emerging ideas and perspectives. So I won't dwell on this, but every version of the guidance has had a visual kind of conceptual model which shows how is it that we do good intervention research. So the blue and pink one comes from the 2000 version, and it really tracks onto what we would see in pharmacological drug testing of modelling, kind of in-person testing, and then rollout. The 2008 version got a little bit more social science informed and was a little bit more iterative. And this is where we are working with the 2021 version. So the MRC prescribes or recommends that in order to develop and evaluate an intervention, we would move through these 4 stages of activities. These stages are iterative. We can move back and forward depending on our emerging evidence. But they say that we will start with the point of developing a new intervention using things such as co-production, PPI, some of you might be familiar with. We might adapt an evidence-informed intervention we saw work in another country, perhaps with another population, or we'll identify an intervention that is in routine practice, maybe the government has rolled out, but it doesn't have an evidence base and we want to build evidence for it. From there, we move to feasibility testing, which is trying to ascertain, is an intervention feasible and acceptable in real-world practice? Can we actually deliver this intervention with our resource envelope? Then we move on to evaluation. So this is perhaps what many of you will be more familiar with, is establishing, does an intervention work? Is it effective and cost effective? And then once we've established the evidence for something and we know that it works, we move on to an implementation phase. So how do we scale up an intervention nationally or within the community of interest? So I said, many of you will be familiar with this, but this kind of is our anchor point for navigating the field of evaluation. But while we have that kind of key overarching guidance, it doesn't really give that much guidance of practical steps of how do we actually do research at each of those phases? How do we actually develop an intervention? So to supplement and really strengthen the overarching guidance, new pieces of specific guidance have emerged and been issued over the last 15 years. So they map across the different phases of guidance, and they really help to support intervention developers and evaluators to actually deliver the work. So I'll just flag what some of these pieces of guidance are. So one of the most recent ones is the index guidance, which was developed by Alicia Kuthun and team. And this was looking at that first stage of the MRC guidance of how do we develop a new approach. So this was kind of endorsed with the MRC. Secondly, and as we mentioned, this was a piece of guidance that I co-led on, which was the ADAPT guidance. So again, that initial box of the MRC guidance, which is how do you take an intervention that's got an evidence base elsewhere and adapt it to your context. So this was issued just 3 years ago. Even more recently, last year, the NIHR commissioned a piece of work looking at how do we actually do natural experimental studies. So historically, there was a strong emphasis on randomized controlled trials as the predominant evaluation design, but this has kind of softened and broadened a little bit, and now they are trying to strengthen methodological robustness around natural experimental approaches. And then finally, the thing that I'm here to talk about today is process evaluation. So back in 2015, the MRC commissioned a further piece of work, a more in-depth piece of work on how is it that we would do a process evaluation across the phases of the MRC guidance. But before we go into the process evaluation, and when I was writing these slides, I was thinking about, well, kind of where do we start to introduce it? And I realized that actually it's quite difficult to talk about process evaluations unless we've introduced the idea of program theory. So many of you, again, will be familiar with this, but it's always worth revisiting it to make sure you kind of understand the concepts related to it. So this visual diagram is the central conceptual model that's in the process evaluation guidance. It's the thing that really guides us in thinking about what is it that we're going to look at, what questions are we going to ask. And in this very first arrow in the box, the black box, it says we start with a description of the intervention and its causal assumptions. So the idea is that before we can even think about questions of was the intervention well implemented, did people find it acceptable, we need to have a clear understanding of what is the intervention that we are looking to deliver. So this kind of intervention is your ideal type, it's the normative referent, it's the thing that you are planning to deliver as part of kind of routinization. It's the thing that you want to evaluate. So as I said, our starting point is we need to be able to describe what our intended, our planned intervention is. And this is kind of where we go back to the MRC guidance and think about, okay, how do we describe what our intervention is? So in the very first stage of development or identification, the guidance, the MRC guidance says that we will really kind of think about describing what our program theory is. And they use the term often intervention and program theory quite interchangeably. And within evaluation science, you kind of will see those two terms used sometimes as substitutes or alongside each other. But the program theory essentially describes your intended intervention. And this is how the MRC guidance defines it, and it's definitely worth going back and reading their guidance on it. So they say that program theory describes how an intervention is expected to lead to its effects, under what conditions. It articulates the key components of the intervention, how it interacts with the mechanism of the intervention, the features of the context that are expected to influence those mechanisms, and how those mechanisms might influence context. So to summarize that a little bit more accessibly, maybe, what your program theory is trying to do is describe what is your intended planned intervention, and it will describe what are the activities that you are looking to deliver. So that might be a counselling session, it might be an information sheet, it might be a social media campaign. But beneath that, it's also trying to understand what is your causal hypothesis? What are the mechanisms, the processes through which your intervention is going to bring about change? So it's kind of your theory of causal assumptions. And then we also think about the context, the real world context into which the intervention is going to be inserted, and how that context will act on the intervention and maybe influence whether it functions well or not. And then to continue that, the MRC says that program theory can be used to promote shared understanding of the intervention. So it really helps us to clarify what is the planned intervention among diverse stakeholders, to identify key uncertainties and research questions. So at the point of kind of clarifying what your planned intervention is, you might think, actually, we don't know this. We aren't quite sure about this. In our process evaluations, we'll actually pick up some of these uncertainties. And just as a useful last point there, where an intervention is developed by others, such as policymakers, researchers still need to theorise the intervention before attempting to evaluate it. So this is, as always, our starting point for any intervention research. Whether you're developing intervention or working with one that's already there, we try to understand what is the intended intervention and what is the program theory. And then again, some of you may be familiar with this, but it's how then do we describe and articulate what our intended or planned intervention is? So there are a couple of tools that are out there which are really useful to engage with if you haven't already. Outside of a narrative summary of what your intervention is, the Tidier checklist offers a really useful tool for standardizing the reporting of your interventions. So it's the template for intervention description and replication checklist. And it really helps when you're doing systematic reviews to be able to kind of consistently see what interventions are. But the reporting checklist asks you to report why you're doing the intervention and why is it going to bring about change, what's going to happen, who's going to deliver it, how will they deliver it, what's the modality, where, what's the setting, when and how much, and what are permissions around tailoring and modifications. And then the second kind of tool we have available to us, which really helps describe what our planned intervention is, logic models. So again, some of you may have used this, but these are visual diagrams or depictions of what your intervention is. So they really are a tool that help us to describe our program theory. And this paper that I've just kind of flagged here is almost 10 years old now by our colleague Eva Rufus and team, and it is targeted to the use of logic models in systematic reviews. But it really, really helps us to think about different types of logic models that are out there. And there's more process-orientated ones, which are quite simple, kind of linear models of intervention. And more recently, this move towards systems-based logic models, which try and integrate context and just are a bit more iterative and sometimes a little bit messier, reflecting the reality of interventions. So I'll just show you a couple of examples of logic models that we tend to use. So the first one was issued by the Kellogg Foundation more than 20 years ago, and it's still probably one of the most commonly used templates out there. So this moves from left to right, and each column describes different aspects of your intervention. So it reports your resources, your activities, your output, so how much of the intervention we expect to be delivered, and then your outcomes and your impact. And your theory or your mechanisms help to hypothesize why is it that we'll move between these different columns. And I've just included an example of a logic model here This was one we did in a study led by Bristol, but with Cardiff, which was trying to deliver a version of mental health first aid training to secondary school teachers to try to improve their mental health. So this, as I said, it was a variation on Kellogg. And on the left, we have the activities or the components. In the middle, we have what we called our mechanisms or our theory about why is it the intervention is expected to bring about change. And then we had the range of outcomes that we anticipate the intervention to trigger. So in this case, we had primary and secondary outcomes, but we also had a range of process outcomes around implementation and acceptability. So just to kind of sum up that bit, and as I said, many of you might be there already if you're doing your own evaluation research, but it's recognizing that before we can move on to process evaluations and collecting data for it, you need to know what your intervention is and have a clear idea of your program theory and have used these tools really to articulate what the program theory is. And you will see more and more with journal publications or funders, they will ask for the tidier template and logic models to accompany any submissions. So now I'm going to go on to process evaluation. So this slide really just gives a very brief history and summary of what process evaluations are. So in the original paper by Moore, so I'm just going to move that so I can actually see the words. In the original paper by Moore and al., et al., they say the updated guidance, which was the 2008 MRC guidance, recognized the value of process evaluations within trials, stating that it can be used to assess fidelity and quality of implementation, clarify causal mechanisms, and identify contextual factors associated with variations in outcomes. So that's kind of gets to the heart of what the original guidance or the 2015 guidance was trying to unpack and kind of show to researchers what it is that they should be doing. But before that guidance was really issued, there was a history of process evaluations, and they emerged in interesting ways, really. So one of the first times that we actually saw the term process evaluation as a concept, as an evaluation concept, was in an introductory chapter in a book by Steckler and Linnon. So it's worth going back and just finding their book about evaluation. It gives you really nice insights really into what they were and how they were conceived in that time. And they very much talked about process evaluation as looking at implementation. And they even used terms like dose delivered and dose received. So they wanted to see about whether an intervention deviated from its intended program because it was or wasn't implemented well, and if that can explain its ineffectiveness. So they were really trying to unpack, were limitations to implementations, were a lack of dosage explaining why an intervention wasn't effective. And within it, we talk a little bit about this idea of a type 3 error. And for those of you who do quantitative research, you'll be familiar with type 1 and type 2 errors. But a type 3 error basically means that we make the right judgment, but for the wrong reasons. And in terms of the process evaluation field, it means that we end up rejecting an intervention when it's ineffective because we think it's a bad idea. We think that maybe our theory wasn't right, our components weren't well designed. We think the intervention just wasn't, it was just a bad idea. But actually, the intervention didn't work because it wasn't implemented properly. People didn't receive enough of the intervention. They didn't interact with it. They weren't exposed enough to the intervention for them to be able to change, for them to be able to experience the mechanisms and then bring about the outcomes. So Steckler and Linnon were really interested in this idea of if we check how much of an intervention is implemented, if the intervention isn't effective, we can very clearly explain it as A, it was a bad idea, or B, it just didn't work because there wasn't enough implementation. There was a lack of dose of the intervention. So that's kind of some of the initial thinking that came up about process evaluation. But more recently, and over the last 20 years, we've seen more of the influence of realist evaluation and complex systems thinking. And a big thing within realist evaluation is this idea of context, mechanisms, and outcomes. And they really want to look at whether interventions worked through the mechanistic pathways that were theorized. So, real focus on, well, why did your intervention work? Kind of what was the causal pathways, the mediators through which we got to our outcomes. And as an extension of that, they're really trying to look at, well, did the intervention mechanisms work for different populations in different contexts? Can and do the same intervention work differently or the same for different populations? So this brings us a little bit more into thinking about moderators. So just kind of to summarize that bit is, in addition to the implementation piece that Steckler and Linnon were interested in, we've now added in this interest in mechanisms. We're trying to explain why an intervention works, not just through outcome evaluation ascertain, was it or was it not effective? So they're kind of the underpinning sort of theoretical concepts and history of a process evaluation. But the second point then really is, well, when is it that we actually conduct a process evaluation? And this, again, is quite messy because it's got a long and emergent history with different people just using it in different ways over time. So really, technically, you can use a process evaluation at any stage of those 4 phases of the MRC guidance. So about 10 years ago, myself included, often used the term formative process evaluation to describe sort of process evaluation methods we would use when developing an intervention. But actually that language has been a little bit subsumed by intervention development frameworks. So we tend just not to talk about process evaluations at the developmental stage, but sometimes people do, and the methods are often similar, lots of rich qualitative methods. Where we do still routinely use process evaluation is embedding them within feasibility and pilot trials or pilot studies, which is the second phase of the MRC guidance. And thirdly, and perhaps most commonly, is we integrate them with outcome evaluations, such as randomized controlled trials and economic evaluations. So that's the third phase of the MRC guidance. About 10, 15 years ago, people would often call these summative process evaluations to differentiate them from formative process evaluations. Now they're usually just called process evaluations integrated into an outcome and economic evaluation. Then the final one then, and this is where it probably is quite murky, is process evaluation at that end point of implementation. So we do use process evaluation methods when we do implementation evaluations, but more and more, depending on who you are, where you're kind of located, you might just describe this as implementation science and not talk about process evaluations. So I imagine that's a little bit confusing, but how do I summarize it? Probably that we would definitely use process evaluations in kind of the feasibility stage and the outcome kind of effectiveness evaluation stage. And you may use some of the methods when developing an intervention or assessing implementation, but that language is always changing. So what I'm just going to do now for the next 10 minutes is take us through the 3 blue arrows and just flag really some of the key components that we would look at in a process evaluation. So you kind of are aware of the 3 key domains that constitute one. So the first thing that we often look at in a process evaluation is this idea of context. So as I said earlier, we have our ideal planned intervention that we really want to deliver in the real world. But obviously, as we soon start to implement it, in social science interventions in particular, we're not really like replicating efficacy. We're often doing more effectiveness evaluations. We're putting interventions into real world where people have agency, they have volition, they don't always do as we would expect or even hope. So we need to understand what this context is and how it's going to interact with and act upon our intervention. So the first point there, context factors shape really how our intervention will work and really kind of influence, will it function as we want it to, or will it morph into something else? So there's a few different models that we use to map out and understand context in our process evaluation. So one of the main ones that's been sort of co-opted from child development studies is the socio-ecological model. And this is an organizing framework that really structures context according to the 5 domains of individual, interpersonal, organizational, community, and policy. And this is probably one of the first tools which brought context in from being background noise in process evaluation to having an organizing framework to help us understand it. The second model, which again is quite old, but we use this all the time, and I still think it is one of the most conceptually developed and nuanced models for thinking about what context is and trying to sort of classify its different domains. So this is the CC framework, or the Context and Implementation of Complex Interventions framework, by Lisa Pfaffenhauer and her colleagues out in Munich. And they classified 7 domains of context which they think might influence whether an intervention functions as intended or not. So geographical, epidemiological, social cultural, socioeconomic, ethical, legal, and political. And the key is not all of these domains will be relevant to every intervention, but it helps us just think through what are the influences that might be at play. So that's the context piece. And then the second piece then, which I think people will feel most familiar with around process evaluations, is implementation. So this is the idea of, was the intervention implemented as we wanted it to? And that really speaks back to some of the Steckler and Linen points that I mentioned at the start. So to kind of reorientate us to this model, we have a situation where we have our planned intervention, the intervention that we think is going to bring about change. We move it into a real world context, which we've just theorized and empirically explored with one of the models I've just shown. And as the context and the intervention interact, this might change what the implementation looks like. You know, it might be that in the context, there's just not enough nurses or there's not enough resources. So there's not enough funding to deliver the intervention at the level that you want. So it ends up, I know the number of sessions is less than we'd expected. So it's that context which really shapes how well an intervention is implemented. And we have a lot of frameworks and models for just assessing, exploring what implementation is. So one of the first models was from that Steckler and Linen book chapter. And they said, well, when we look at implementation, there are 6 key domains that we would think about as important to measure. So first is reach. So did you reach your intended participants? This is really useful to think about because it has a clear health and equity dimension to it. Then we had dose delivered and dose received. So was the amount of intervention intended delivered? And did people show up and actually receive it? We tend not to use the word dose so much anymore, but that was kind of some of the original language in it. Fidelity then is, was it delivered as planned? So if people were meant to go to a counselling session for 50 minutes, did it last for 50 minutes? Did it stop after 10 minutes? There might also be certain skills that we expect facilitators to perform. This is often true in interventions around behavioural science or motivational interviewing, but we expect certain techniques by the facilitator. Fidelity is, was that actually delivered? Did they do it? Implementation is a composite score of the other factors. And then recruitment then is, what were the recruitment experiences of participants, and how did that affect reach? So that was kind of one of our first starting points for thinking about this. And then one of the more influential models, which is still used quite a lot, is Carroll's framework from implementation science. And this links adherence, implementation as a set of moderators on the pathway to outcomes. So it's worth going and having a look at that and seeing. But we are seeing more like maybe social science informed or more nuanced models come into being. Just some really interesting work being done to conceptualize and measure implementation. So I haven't got this, but Russ Glasgow's work around the REAIM framework remains popular and is really useful. And this is a model that's gained a lot of traction in recent years, and people seem to really like it, which is the normalization process theory. So that's from Carl May's team. And yeah, it's just a really, really nice theoretical model where it talks about implementation being reliant on the coherency of the intervention, cognitive participation, collective action, and then reflexive monitoring. So I would encourage maybe having a look at that as something that might be of interest to you. So that's kind of just a brief map of implementation and that we would expect to look at implementation in a process evaluation. And then the final domain we will look at, this gets a bit conceptually messy, so bear with me on this bit, but it's this idea of mechanisms of impact. So this is actually what the causal pathway is to getting your outcomes achieved. So mediators, perhaps for those who are a bit more quantitatively minded, might be a useful way of thinking about it. But essentially, mechanisms of impact, it speaks to people's interaction with the intervention and how it starts to trigger a causal pathway of change. So it explains how when people take part in the implemented intervention, how do we get to the outcomes? So for a lot of you, that will be how do we achieve the behavioral change we're looking at? But that activation and mechanisms piece, it kind of sits with a range of other concepts, and people often talk about it in terms of acceptability. So was the intervention acceptable in a way that people interacted with the mechanisms and responded to them? So I've just said here that acceptability is often understood as how people interact with the intended causal pathway. So it's based on the assumption that the more acceptable an intervention is, the more people are likely to interact with the intervention as intended, and the mechanisms get activated, and you achieve the outcomes that you're interested in. Conversely, when people do not find interventions acceptable, they might just not interact with the mechanisms at all. Even if it's really well implemented, they might just not engage, and so mechanisms aren't activated, outcomes will not be realized. The third one, which is really important here, is people might just find interventions unacceptable, but they might also just not interact with it in quite the way that you want. So it might be something different from complete disengagement. They just interact in a slightly different way, and this triggers harmful causal pathways and leads to harms. So you're not only not achieving the outcomes that you wanted to, you're actually leading to unintended consequences and iatrogenic effects. So an example here might be that some people from certain underserved communities find the intervention is unacceptable, so they don't engage, and the unintended impact is we get health inequities because we only see certain privileged groups achieving positive outcomes. I just want to put as a small caveat there that there are lots of cases where unacceptable interventions are actually really effective, and the effectiveness comes from they demanded a lot of change and they were just really difficult for people to kind of cognitively engage with. So it's not a given that all of this holds together, but it's kind of just the general sort of thrust of thinking in it. So acceptability, probably along with sustainability, are two of the most underdeveloped concepts within process evaluation. But there has been some work over the last few years to theorize what does acceptability mean to people and how it kind of relates to them interacting with the mechanisms and actually leading to change. So there was a great paper by Cynon, nearly 10 years ago now, which looked at the 7 domains of acceptability that we might want to think about. So when we're interviewing people, when we're assessing things, we might want to think about, do people perceive this to be a burden? Do they feel good about an intervention? Does it have coherence to them? Does it make sense? Is it perceived to be effective? Outside of whether it's actually effective or not, do people believe it's creating positive change, which then is leading them to engage with the mechanisms and perhaps bringing about real world effectiveness? I think a really interesting dimension of this model at the bottom is the difference between prospective, concurrent, and retrospective acceptability. So often when we do process evaluations, if, for example, we're doing interviews, we might do phases of interviews across the life course of a randomized controlled trial, just to kind of get a insight into whether acceptability is changing. People might start off really optimistic about an intervention, but then it gets hard, they disengage a bit, and their concurrent acceptability declines. So it's worth always keeping that temporal aspect in mind. Then the last couple of slides I just want to flag here really are kind of what's often called the dark logic of acceptability and the potential for harms or unintended consequences. So we definitely get it in public health whereas clinical trials tend to be very risk aware and very aware of harms because death can be a serious adverse event. In public health, it's often the fear or concern is more that just an intervention just doesn't work, it's ineffective. But there are lots of examples where we do see harms coming from interventions that comes from this interaction with the intervention mechanisms. So Chris Bennell's done a lot of work here, talked about direct harms. Sorry. So sorry. So there's direct harms, there are psychological harms, but the three I just wanted to flag here. First is health and equity harms. The health promotion interventions are often taken up by those who need them least. There's also groups and social harms. So certain targeted interventions can lead to negative labeling and stigma within certain risk groups. And then opportunity harms, which is massively underexplored. But this really speaks to the idea of your intervention requires resources, it requires funding, and for that to happen, resources have to be taken elsewhere from the system. And there's a risk that that redirection of resources, withdrawal of intervention from elsewhere, might stop something really beneficial from happening for people. So you have to think about the costs that your intervention is having in the wider system. So this is a very new framework, but it's just really helpful for thinking about those harms. It's called the consequent framework. So when you're doing a process evaluation, it's kind of worth trying to structure some of your thinking within this. Then the last framework I just wanted to flag really is around that health equity piece. And this is the Progress Plus model. And this is really useful primarily again for systematic reviews, but it's a classification system for creating strata according to the social characteristics which might experience health inequities. So I would probably just have a look, especially if you're interested in underserved populations, how that sort of classification system works. So we're nearly out of time, but I will just spend a couple of minutes going through these last few, because I think it probably is worth me sharing these bits. So that's kind of the conceptual piece of those 3 dimensions of process evaluations that we will look at. But then just thinking for the last couple of minutes about the practicalities of actually doing this. So when you are designing a process evaluation, the key thing we often teach in our teaching is that all process evaluations are different. So it's definitely worth looking at them and seeing what other people have done. But the idea is that you tailor your process evaluation to your intervention. So they will often tend to have similar components. Usually all of them will look at context, implementation, acceptability, but how they really center their efforts, what uncertainties they focus on, depends on the intervention of interest. So when you're trying to decide on the parameters of your process evaluation, it's really important to go back to that program theory piece and try and think about what do we not know? What are our key uncertainties? Where do we need to collect data here? What are our kind of key weaknesses and areas of strength in knowledge about the intervention? And what do we need to know about the context? So it's really about tailoring what you're doing according to your uncertainties. And then similarly then, the research questions, they will tend to map onto those domains of your implementation, your context, your mechanism. Nearly every process evaluation will ask something about, was the intervention delivered with fidelity, for example. But what you really need to think about is sensitizing those questions to your process evaluation. So I've said an example there, most process evaluations will consider acceptability, but for you it's really thinking about, well, who are the involved parties that you want to explore this with. So acceptability to professionals, acceptability to patients, acceptability to carers, for example. And the last couple of slides then is thinking about process evaluation. So whereas in other study designs you have very clearly specified methods, process evaluations can draw on and make great use of any type of research method. So really encourage you to think really broadly about what methods you would bring to it. But the methods need to be informed by the research question. They need to be able to generate the data that will answer your research question. So just flagging there, process evaluation doesn't answer questions of effectiveness, and sometimes people can conflate the two. So it's just questioning yourself, the what, where, whom, when, how sort of considerations, just to really try and refine, are the methods kind of meeting these particular questions. And I've just flagged here, some of the methods that we've used in process evaluations. And as I said, essentially you can use all methods. So we often use, qualitative narrative auditing to try and understand context of hospitals, of schools, interviews, focus groups, observations of implementation, ethnographic methods, and then, audits, questionnaires. So, that can be like post-training satisfaction, observation data. So particularly around fidelity, it can be checklists. Did they cover this material? Scoring of 0, 1, etc. Right, so I have gone 5 more minutes than I'd expected, but hopefully that's okay. So I'll just bring it to a summary. And obviously, I completely recognise that as a whistle-stop tour of what process evaluations are. And you'll probably be leaving more questions than anything. But it'll hopefully just help you to start to navigate that space and give you some of the key frameworks that you might be able to take away and explore some more. But the headline thing is that process evaluations are a vital part of evaluation research. And for some research funders, they are essentially mandatory, and it would be very difficult to get an outcome evaluation funded without integrating a process evaluation, because they are seen as being key to understanding, why an intervention is effective or ineffective, and if the issue is the intervention's based on poor causal assumptions or if it's an issue of implementation. And as I said, so no process evaluation is the same, but they do tend to have these pillars of inquiry that they all will look at, and then they get tailored to your individual intervention. And then just a lot point then about the methods. It's really a very mixed method approach. So traditionally with Steckler and Linnon, they were much more quantitative, but they really make use of qualitative methods and qualitative creative methods these days. So I would really encourage you to look into that also. So just finished to say thank you very much for taking the time to listen to me. And we'll circulate these slides, but it was just to flag this is our website for our Research Centre short courses. We have lots of short courses that we deliver internationally. And then this is our website for the ADAPT guidance specifically that I mentioned.